Hey everyone, welcome to this month's CME. This portion of the CME we're going to discuss 12-lead EKGs. We're going to go over some of the when, why, and how to perform a 12-lead EKG, discuss the components of a 12-lead EKG, steps to reading a 12-lead EKG, and identify and discuss axis deviation and blocks, which will include hemiblocks. We're also going to identify and discuss STEMI mimics. Okay, so we're going to discuss when we're going to do a 12-lead EKG. So the following patient should receive a 12-lead EKG. Anybody with difficulty breathing, syncope, palpitations, unexplained nausea, any patient who's complaining of an unease feeling, diaphoresis, any unexplained jaw, arm, epigastric, or shoulder pain, any patient that we get ROSC on after cardiac arrest, after epinephrine administration, and after nitro administration, we want to do a 12-lead as well. We're also going to discuss some of the protocol of C3, which is our mom's protocol, which is our ACS protocol. So what exactly am I looking at when I look at an EKG? Well, EKGs are a direct representation of the electrical conduction flow within the heart. It's not the actual contraction of the heart muscle, but it's the wave of electricity or voltage that's moving through the heart. It's measured in millivolts and millimeters, and the direct correlation of depolarization and repolarization of the atria and ventricles. Okay, so let's discuss how to do a 12-lead EKG and what exactly each one of the leads is looking at when we're doing this. So 12 leads are accomplished by placing the leads on the patient's body. The conduction moves from the positive to the negative in the limb leads. So 4 limb leads produce 6 views of the electrical conduction system of the heart. These are called frontal leads, or bipolar limb leads, which means that the electrical impulse moves from both positive and negative electrodes. 4 limb leads consist of the right arm, the left leg, and the right leg. These limb leads give you 3 different lead views: lead 1, lead 2, and lead 3 on your EKG. There's also augmented leads. These are unipolar limb leads. These leads are augmented view, hence the term AV. They look from the right, the left, and the foot, which indicates a placement of the positive lead. Leads originate from the CT, which is called the center terminal. This is the center of the heart. Impulses move from the associated positive leads to the center terminal. So in other words, they're moving from the right arm to the center of the heart, the left arm to the center of the heart, or from the foot or the left limb lead to the center of the heart. These give you multiple views or different views of the heart from different angles with the 4 limb leads. These are going to be your AVR, your AVL, and your AVF leads. There's also 6 precordial leads. These are called horizontal leads. The reason they're called horizontal leads is because they kind of cut the body in half and look at the heart in 6 different ways. This is going to be your V1 through V6, and these all are looking at different parts of the surface of the heart. All right, let's look at some of the leads of the heart and what they're looking at, and a term that's called Einthoven's triangle. This makes up leads 1, 2, and 3. This is used to determine axis deviation. Lead 1, conduction moves from the right arm to the left arm, views the left side of the heart. Should be a positive deflection in lead 1. Lead 2, conduction moves from the right arm to the foot. This views the bottom of the inferior aspect of the heart, looking toward the right arm, and should be a positive deflection in lead 2. Lead 3, conduction moves from the left arm to the foot, views the bottom of the inferior aspect of the heart, looking toward the left arm, and this should be a positive deflection in lead 3. All right, let's look at the augmented leads now. So the augmented leads are unipolar limb leads. Leads use an augmented view, hence the AV. The R, L, and F that follow the AV indicate the placement of the positive lead. So for AVR, it's on the right. On AVL, it's the left arm. On an AVF, it's the foot or the leg lead. The conduction originates from the respective positive lead and moves to the CT, or the center terminal of the center of the heart. Impulse moves from the associated positive lead to the center point. AVR, you should have a negative deflection. AVL should be a positive deflection, and AVF should also be a positive deflection. So let's look at our precordial leads. Precordial leads look at specific areas of the heart. It's very important to place these precordial leads in the correct anatomical locations. So V1 is on the 4th intercostal to the right of the sternum. V2 is at the 4th intercostal to the left of the sternum, and V1 and V2 view the septum of the heart. V3 is placed between V2 and V4. V4 is the 5th intercostal space in the mid-clavicular line. V3 and V4 are anterior views of the heart. V5 is in the 5th intercostal space on the anterior axillary line. V6, 5th intercostal space at the mid-axillary line. And V5 and V6 view lateral as a lateral view of the heart. This chart represents the views of the heart from each lead. For instance, V1 and V2 are view the septum, V3, V4 view the anterior of the heart, and V5 and V6 view lateral. Okay, so as you can see in this picture, this color representation of the leads of the 12 lead that are associated with the coronary arteries that could be affected. This is a really interesting view. It gives you an idea of which coronary arteries are affected by each part of the view that you're looking at through the EKG, and it can kind of give you an idea of how much damage could possibly be done, be it the left coronary artery, right coronary arteries, circumflex arteries, what have you. So let's talk a little bit about waveforms. Waveforms are the movement away from the baseline in a positive or negative deflection. So they can go above the isoelectric line or they can go below the isoelectric lines. Anything that moves above and beyond or above and below is considered a waveform. Okay, so this is the T wave. The T wave represents the repolarization of the right and the left ventricles. Usually represents the tallest T wave when looking at it in lead 2. All right, so let's talk about segments. Segments are the lines between the waveforms. We're going to talk about a couple different segments in this slide. So we have the PR segment, which is a measurement from the end of the P wave to the beginning of the Q wave. This represents the activation of the AV node, the bundle of His, bundle branches, and the Purkinje fibers. Next, we're going to talk about the ST segment. This is a measurement from the end of the S wave to the beginning of the T wave. It represents the early part of repolarization of the right and the left ventricles, and the junctional point of the QRS and T wave is called the J point. This is where this measurement starts. Okay, so we're going to look at intervals now. So the first interval we're going to look at is the PR interval. This is a measurement from the beginning of the P wave to the beginning of the Q wave. Normally measures 0.12 to 0.20 seconds in adults. Anything greater than 0.20 seconds could indicate a delay of the signal through the AV node. Some things that could cause these AV node delays could be beta blockers, calcium channel blockers. Patient could have a first degree AV block, hypothyroidism, or digitalis toxicity. A PR of less than 0.12 seconds would indicate that the impulse originated from an ectopic area other than the SA node. Could also indicate that the signal did not pass through the AV node, such as Wolff-Parkin's-White syndrome. Next, we're going to talk about the R to R interval. This is used to determine rate and regularity of an ECG. It's used to measure the ventricle rate. The P to P interval is used to determine the rate and regularity of ECG as well, and it's used to measure the atrial rate. Those should be the same. ST interval measured from the J point to the end of the T wave, and the TP interval is the end of the T wave to the beginning of the next P wave when the heart is actually silent. The QT interval represents the entire depolarization and repolarization timeline. It's measured from the beginning of the QRS complex to the end of the T wave. To determine the QT interval, this is a little bit of math we have to do now. We have to measure the R to R interval and divide by 2. Measure the QT interval and make sure that it's less than half the R to R interval. If it's less than half, it's considered normal. A QT greater than half the R to R interval is considered a prolonged QT. Prolonged QT places the heart in a prolonged vulnerable period. This is where the R on T phenomenon could occur. Causes of prolonged QT could be an electrolyte disorder, anybody who's been given amiodarone, and then you could also have a shortened QT interval. This could be caused by digitalis or hypercalcemia.